I was going to ask, and now that I'm saying it, I'm going to ask you, are you going to talk about the four-letter word that doesn't start with F?
I don't know. What is it?
It is the word that, just a little bit of our personal history. We met in Sweden about a year ago. And you came to me encouraged, and I realized that it's not just the orthopedic surgeons or men, or at least orthopedic surgeons, who need a little bit of encouragement from a bottle to be able to reveal some of the deepest secrets. So you mentioned something. Are you going to talk about it here, or should I talk about it?
You talk.
Okay. Maybe I will. Okay, first of all, about my disclosure, I do take money from various sources for my research, but I don't generally take money from the pharmaceutical industry. I have made one exception so far for an osteoporosis conference. I did end up donating the money to All Trials campaign, and that really is the biggest message of this talk. If you don't know what All Trials campaign is, Google it. The power of nothing, and I guess I've always been intrigued by great titles, and I think this is a great title as much as it is misleading, but I'm trying to tell you why someone can see placebo as a bad thing. So this is what we are traditionally used to, and this is what our orthopedic practice pretty much relies on. Studies like this that show something that we did. This was the situation before the trial here, and then eventually things get better, and I am a bit hopeful that this is eventually changing, but a lot of do keep in mind that a lot of our practice is still based on evidence like this. So does it really work? This paper was published about 2 years ago. It's a review of all sham surgery controlled trials published so far, or published at the time. And what was so eye-opening for me was this conceptualizing of the treatment effect. And I think this is something that every orthopedic surgeon should be made aware of. So we are talking about the response that we just saw, and Rainer, I know you briefly touched on this, but just to kind of summarize and repeat some of the stuff. So this effect we showed from 50 to 80 or whatever is composed of three components: the non-specific effects, the critical element of surgery, and the placebo effects. So what is the critical therapeutic element? And this is something that you should really think about. When you are doing something, especially for subjective symptoms like pain, you usually either cut something or you reconstruct something. And that's the critical therapeutic element. Everything around it, you either go to the site to do it, but that has nothing to do with the alleged therapeutic element. And then you have, so for example, in our study, in our fidelity trial, it was the resection of the meniscus, not going there, not the keyhole arthroscopic surgery. It has been shown not to have any therapeutic component or effect. And then you have the non-specific effects, and those were the ones that Rainer beautifully explained, the natural course of the disease. Keep this always in mind when you do something and when you observe healing response, and then the regression to mean. And then we have the placebo effects. So going back to this study, 53 trials so far, maybe a few after this in the past 2 years, not too many. And when you look at the evidence, this is the history of surgery in one study. So In half of the included studies, so 49%, and these were conventional surgical practices, something that is being done in masses. The authors reported superiority of the surgical procedure over the placebo intervention. And in the rest, so basically half of them, active surgical procedure was not statistically different from the placebo intervention. So half of the stuff that has been tested has been shown to be nothing but placebo. When you look at medicine, it's a trail of broken dreams. Most of our medical practices in general are things like this. If something looks like a credible treatment, then it must be so. I'll give you a few examples. This is treatments for myocardial infarction induced premature ventricular complexes. So for orthopedic surgeons, they look like this. This is the EGG, and they look like this. We have drugs that are supposed to decrease the occurrence or incidence of these. So of course, 1 + 1 is 2, so it has to be an effective treatment. This is a practice Paul probably remembers well, a practice that couldn't even be disputed, couldn't even be tested, because the field was so convinced that when you see the disappearance of these, it has to be an effective treatment. Until it took these people years to convince some cardiologists to test it. When they tested it, it actually was shown that these drugs kill people. So what about control of glucose in type 2 diabetes? When you look at the literature, virtually anything is increased. The risk of anything is higher due to type 2 diabetes, like the risk of death, blindness, fractures, depression. You can pretty much put any imaginable disease and you will see an association, increased risk of that with diabetes. So prospective follow-up studies, they have shown that the higher the long hemoglobin A1C, the higher the risk of everything bad. So how do doctors think? What we have to do is we have to lower the glucose levels in the blood. The lower we get them, the better our patients will do. Until this trial that tested 2 different protocols, an intensive glucose lowering protocol versus a little bit less stringent one. And here are the results. And this is how medicine has in the past been practiced. What you get what you measure. So they were measuring glucose levels, and you could see that the therapy, the treatment works. So these people had lower glucose levels in the blood. What about something that matters to the patient? Again, this treatment, the more intensive treatment, killed people. I think this is the most beautiful example of why placebo is bad, or why we have to be aware of placebo. Hypertension. One would imagine that something so objective, we can't control. There is no way we can control our blood pressure. There can't be a way we can control our blood pressure. Somebody came up with an idea that blood pressure, sorry about that, is controlled by the neural network around your kidneys, the renal arteries. So, to be able to insert a device like this and try these little bastards around the vessels, you are able to lower your blood pressure. And this is exactly what the non-randomized studies show. Non-randomized study showed a response that had never ever been seen before. Even 40 units of change in blood pressure, in systolic blood pressure, after this kind of treatment. So what about when people were randomized to this treatment? But the response was a little bit smaller, but we are still talking about 20 to 30 units of millimeters of mercury. How was the blood pressure documented? By a doctor who was made aware, or who was aware of the allocation, which of the patients had the treatment and who didn't. So next phase, non-randomized studies, but automatic measurement of blood pressure. What do we see? From roughly 30 to 20 to something in the range of about 10 units of systolic pressure. Randomized studies, we are down to 5. And then all of these were unblinded studies. Then the last study with blinded, automatic storage, randomized, doctor unaware of the allocation, and the entire treatment effect disappeared. Whenever something like this comes out, doctors of that discipline are so frightened and are so frustrated, are very aggressive, feel like somebody has killed their precious child. But this isn't, when you think back, when you started practicing medicine, there were treatments that your predecessors had developed, and then you wiped them out, and you had no problem with that. And all of a sudden, you now feel that we have reached the final stage of medical evolution. We are right now on the top of the pyramid. History doesn't support such illusion, but that's how people behave. Here is an example, a study that reviewed all the papers published in the New England Journal of Medicine between 2001 and 2010. And they classified them as replacement if it was testing a treatment. These are all the studies that were testing a treatment. It was called a replacement if the new treatment was better than the current established practice. Back to the drawing board if the new treatment was worse than the established practice. Reaffirmation if the established practice was better than doing something less or doing nothing. And reversal if the established practice was actually worse than doing nothing or doing less. And I'm going to focus on the reversals here. So 2,044 articles, 66% concerned a medical practice. Of these, 27% tested an established practice, something that was people were doing currently. Of these, 40% found the practice no better or worse than doing less or doing nothing. So it's, ladies and gentlemen, arthroscopic partial meniscectomy is not a rarity. It is actually a common feature among interventions, medical interventions. Going back to the placebo effect, this is, so whenever we see an effect, whenever we go from 50 to 80, we have a 30-point whatever effect in pain. So basically, when we have teased out how much is attributable to the actual critical therapeutic element, how much is placebo and how much is no treatment, this is how it is overall. But when we start looking at things like chronic pain, which we mostly treat, no treatment has really no effect there. Placebo has quite a big, so 40% of the treatment effect in general has been attributed to placebo, and the rest then to active treatment. Maybe I'll skip that. So what's the evidence for contemporary medical practices? So when people have tested how much of our current practices stand on high quality evidence, overall about 40%. Some disciplines are pretty good, like internal medicine. I wouldn't be so convinced about that. Psychiatry, but surgery, about 1/3 of our practices have been validated by any good, valid evidence. Just to look a bit deeper into our practices, this is a recent study by Ian Harris and his group from Australia. Less than 50% of the volume of a big orthopedic unit in a city was supported by any evidence, and less than 35% of the procedures. So I'd like to end my story by a very beautiful comparison of surgeons and shamans. A modern operation starts with a series of events resembling ritualistic practices used by shamans. And maybe I will now shut up and let you read this and think then about the little rituals that you do when you prepare the patient for the operation, what takes place. And these guys have been doing that about 2,000 years ago, and I have a feeling that we haven't progressed as much as we would like to believe. With that, thank you.